Today, we'll discuss the immunosuppressive drugs and their side effects, but still, it is inevitable that they have to be used to protect the graft from getting rejected. And these are the commonly used immunosuppressive drugs. That is azathioprine, which has a trade name called as Imuran, methotrexate, which has been commonly used for even rheumatoid arthritis, as well as osteoarthritis, methotrexate, cyclophosphamide, very dangerous and highly toxic drug, cyclophosphamide, which is also called as nitrogen mustard, and it is also used as a gas. And it is believed that with Agent Orange, it was used in Vietnam War. It was sprayed in Vietnam by America to cause mass killing of the soldiers. Cyclophosphamide. Cyclosporin, which is called as wonder drug of transplantation. At the same time, some limitations are also there with this drug, which I'll tell you later. Then corticosteroids, which are commonly used for most of the inflammation inhibition reaction. It is an anti-inflammatory drug, corticosteroid. Even for cancer treatment, corticosteroid. We'll start with azathioprine. This is the structure of azathioprine. And please pay attention to this part of the structure, which has the resemblance to purine of the nitrogenous base of DNA and RNA, purine. So on administering this drug, azathioprine, it gets metabolized and cleaved at this junction where it is linked with another heterocyclic ring with sulfide. The sulfur bond with the heterocyclic ring is broken and sulfur is retained by the purine, and then it becomes 6-mercaptopurine like this, 6-mercaptopurine, which is a pseudo-nitrogenous base. And this pseudo-nitrogenous base has equal affinity and capability to get itself substituted in the DNA during the replication of the DNA or in the RNA when the RNA being transcribed. So whenever it gets incorporated in the DNA during the DNA replication, there is a possibility that that particular DNA molecule will become useless later for transcribing. The gene will be silenced because this nitrogen base, like 6-mercaptopurine, which is substituted as a substitute for any of the purines like guanine and adenine, or that DNA will be useless. And whenever it is interfere with the next generation of cell cycle and prevents DNA replication, the DNA polymerase enzyme, which is running on the DNA strands, leading strand and lagging strand, when it comes to the junction where this mercaptopurine is substituted in the DNA, there the enzyme stops. It does not proceed further. So thereby inhibiting the DNA replication. And suppose if it is incorporated in the transcribed RNA, that is mRNA, the ribosomes will fail to pass beyond this purine nitrogenous base if it is there in the RNA, and it will not be read as a code. So therefore the ribosome dislodge and the translation process gets terminated. So that is how it will interfere. On administering this, you know that the T cells that are proliferating or B cells that are proliferating because of their activation by the antigens be inhibited from proliferation, because those proliferating cells will be attacked at the stage of DNA replication or transcription. Okay, there are other mechanisms of action of this azathioprine. Please remember, now when I'm talking about proliferating cells, It need not be only immune cells. T cells are proliferating, B cells are proliferating when the immune system is activated. But at the same time, remember, there are cells that are proliferating in your body to keep the functions normal. That is intestinal epithelium and bone marrow. The bone marrow is a continuously dividing region in your body where it is supplying the cells that are required for the immune response. Okay, so bone marrow will be affected. Overall, bone marrow gets inhibited in the replication, and here in the intestine also there will be inhibition. So, what are the other mechanisms of incorporation or inhibition by 6-mercaptopurine? Azathioprine by itself will not be active. It has to be broken down in the body to 6-mercaptopurine. And then when it is broken down to 6-mercaptopurine, it has the ability to bind to ribose sugar in this region of the nitrogen or deoxyribose sugar and form a pseudo-nitrogenous base of the DNA or RNA. And when it binds to the ribose sugar, it is called as ribotide, RIBOTIDE, ribotide. And that ribotide, when it is there in the pool in the cell cytoplasm, with the pool of other nitrogenous bases of the nucleic acid, that purine nitrogenous bases of the nucleic acid, it will form an inhibitor, that is competitive inhibitor of the enzymes. Same like the enzymes getting inhibited by a pseudo substrate. Okay, so the ribotide will inhibit the enzymes which are responsible for the synthesis of guanylate acid and adenylate acid, which are the precursors of guanine and adenine. So, because ribotide acts as a competitive inhibitor of the enzymes of synthesis of guanine and adenine, the pool of guanine and adenine will be deprived in the cell. The purine nitrogenous base pool will be deprived. If the pool of these two purine nitrogenous bases is deprived, the cell will have to stop replication because these two nitrogenous bases are very essential, whether it is DNA is concerned or the transcription process is concerned. They are required for the RNA as well as for the DNA. By inhibiting the purine nitrogenous base, the entire process of cell replication can be inhibited. So that is how they interfere with the cells at the mitotic stage or replicative stage by depriving the cell of the purine nitrogenous base pool in the cytoplasm. Okay, and I've already mentioned about they act as pseudo nitrogenous bases by substituting in the DNA and RNA. That is how they interfere with the replication of the DNA as well as transcription of the RNA. Now we'll take the second, another important immunosuppressive drug, which is slightly milder compared to the previous one, azathioprine, and commonly used for treating the rheumatoid arthritis patients as well as osteoarthritis patients. Even it is also used in autoimmune response for treating patients to relieve them of the symptoms. Okay, it is a major inhibitor of folic acid, and folic acid is the precursor. It is the precursor. If you refer to the metabolic pathway of nitrogenous base synthesis in the cell cytoplasm, folic acid becomes the major precursor of all the nucleotides that are going to be synthesized in the cell. That is, whether it is purine or pyrimidine. First, folic acid is going to get converted into pyrimidine nitrogenous bases. Then it is getting converted into purine nitrogenous bases in the pathway of the nucleic acid synthesis, that is nitrogenous base synthesis. There is an enzyme called as dihydrofolate reductase, and dihydrofolate reductase is active only when the folic acid is available, and it is responsible for conversion of folic acid to nitrogenous base precursors. So it is observed that the methotrexate inhibits the folic acid, and conversion of folic acid is inhibited by acting on dihydrofolate reductase. Therefore, the nucleic acid precursors, that is intermediates that are required for pyrimidines and purines using folic acid will not be synthesized in the cell. So the cell will be active in this process of synthesis of the precursors of the nitrogenous bases in the S phase. G0, G1 and S phase are the most active stages of the cell cycle, preparing the cell to divide. At that stage, cell will prepare all the requirements that is required for the division. So the cell will also synthesize sufficient number of purine and nitrogenous bases required for the DNA synthesis and for the RNA transcription. By inhibiting the precursors of nucleic acid, one can inhibit the cell cycle. So methotrexate acts at the root of the cell cycle, where the precursors of the nitrogenous bases are not going to be synthesized using folic acid by inhibition of the folic acid, and thereby preventing the cell from dividing. This is the another immunosuppressive drug which acts on T cells as well as B cells which are proliferating, as well as it may act at the bone marrow level, preventing the precursor B cells and precursor T cells from being dividing or providing the cell the required precursors. Okay, so now then comes the cyclophosphamide, which is a very toxic drug. Look at the structure of this cyclophosphamide. Has got two chlorides at the terminal end, and this is the alkyl residue. So since these two chlorides are very active, they can form bond with the nitrogenous bases of the DNA and form DNA adduct. Irrespective of purine and pyrimidine nitrogenous base, these chloride residues can link with the nitrogenous bases to form DNA adduct. Now, you imagine a situation where one of this chloride is linked with one nitrogenous base of one strand, and this chloride is linked with the another nitrogenous base of the other strand. Thereby, it will cross-link both the strands in such a way it will be placed in between the two strands of the DNA, and it will be in between cross-linking the two strands and then prevent the unwinding of the strand. Remember, when the DNA has to be replicating, it has to unwind, and that unwinding process is done by the enzyme helicase. And the helicase facilitates unwinding of the strands. When the single strands are generated, they are bound by the single strand protein, single strand binding protein, which keeps these strands apart so that the DNA polymerase can move over the strand to synthesize the complementary strand. Now, if cyclophosphamide cross-links the DNA strands by attaching itself to the opposite strands through this chloride linkage, it will prevent the strand from unwinding. At the unwinding stage itself, it can inhibit the DNA replication. One. Second, by forming an adduct with the nitrogenous bases, okay, when it forms with the nitrogenous bases, the process is called as alkylation, because this is the alkyl residue, and by bonding with the nitrogenous base, this alkyl residue together with this pyridine ring will be attached to that nitrogenous base. That process is called as alkylation, and that alkylated DNA, the DNA adduct which is formed, will be not functioning because that DNA strand will have an additional residue attached to the nitrogenous base. Because of the attachment of this to the nitrogenous base, if at all the DNA is not cross-linked, if at all it is getting ready to undergo replication, or if at all it is getting ready to transcribe the messenger RNA, the enzyme that comes to the part of the nitrogenous base, when it comes there and finds that that nitrogenous base is linked with another chemical molecule attached to it as an adduct, that the enzyme will not be able to move further from that nitrogenous base. It will stop at that point and the DNA replication gets terminated. Similarly, if the transcription process has to start, if the DNA adduct has already been formed by the cyclophosphamide, the DNA transcribing enzyme, that is RNA polymerase enzyme, which is running over the single strand of the DNA to synthesize the complementary strand of the RNA, will stop at the junction where cyclophosphamide has formed the adduct, thereby termination of transcription at the early stage. Okay, at the early stage itself. So proper mRNA will not be synthesized. This is how the cyclophosphamide will interfere with the cells. And vulnerable stage of the cell is the single-stranded stage. When the DNA is becoming single-stranded, the unwinding process has already begun and the DNA replication process has to begin. At that time, the cyclophosphamide will go and bind to the single strand, because the single strand of the DNA is naked DNA strand. It is not protected by histones. Okay, cyclophosphamide forms the DNA adduct with the DNA when the DNA strand is naked. When the histone is present, cyclophosphamide cannot act on the DNA. Histone will protect the DNA from the action of cyclophosphamide. So, when the cyclophosphamide is in circulation in a person, as the cell gets prepared to replicate the DNA unwinding process begins. At that time, the cyclophosphamide, if it's available in the nucleus of the cell, it can transfer easily across the plasma membrane of the cell and reach the nucleus. It will form the DNA adduct. Once it forms the DNA adduct, it is the permanent feature. That cell has to die. It will undergo apoptosis. Whichever the cell, the DNA adduct is formed with cyclophosphamide, that cell is going to go for apoptosis. And remember, it cannot discriminate between only the immune cells and other cells of the body. Whichever the cell is preparing to divide, it is going to act on that cell at the stage where DNA is naked. Therefore, intestine, which is replicating, that intestinal epithelium on daily basis, which is replicating and forming the new epithelial layer, is also under attack. Bone marrow cells are also under attack. Thereby, it will suppress the immune response by interfering in the bone marrow level, or by interfering with the T cells and B cells which were activated against a particular antigen. Okay, and they were prevented from dividing now. Why? Because DNA adduct is formed in those cells, and those cells which had DNA adduct will be undergoing apoptosis, dying, and it acts indiscriminately. Therefore, it is known to cause diarrhea in the patients, because intestinal epithelium will be highly damaged because of the cyclophosphamide. Very toxic drug, but there is no option. In a minimal dose, it is being used at present for immunosuppression in cancer patients as well as the patients who receive transplantation. Also, it is used as an experimental tool to study the DNA architecture and other things, because it cross-links the DNA and changes the architecture of the DNA, cyclophosphamide. So next we'll talk about the cyclosporin. Cyclosporin A, it is called as, I have not put that letter here, capital A, cyclosporin A wonder drug. It is a peptide of 11 amino acids, and since it looks like a cyclical, it is called as cyclosporin. Okay, cyclosporin. The NH2 terminus of this peptide is linked back with the COH terminus of that same peptide by creating a circle. It is a circular peptide having only 11 amino acids in it, and it is a fungal metabolite produced by a fungus. Okay, Called as a wonder drug of transplantation because for majority of the transplants it can be used, but for some transplants it cannot be used because it doesn't work. The reason is unknown, and but for majority of the other transplant like bone marrow transplantation I had already discussed with you yesterday. For the GVHD disease or GVHD syndrome, it is used to prevent the escalation of the GVHD. GVHD escalation can be prevented by administering cyclosporin A to the patient who has received the bone marrow. Similarly, it is used for the liver transplantation, heart transplantation, and other organ transplantation, except for the kidney transplantation. Okay, except for the kidney transplantation. The reason unknown, but it is known that if the cyclosporin drug is in excess, the kidney gets damaged. It is nephrotoxic. That's the only reason probably it is not used for kidney transplantation. Probably. But we are not sure because there are no reports indicating like why it is not working in the case of kidney transplantation. Fine. So this drug, the cyclosporin, which is a very simple peptide micromolecule of protein, can be easily transported across the membrane, and it is very specific to T cells. It acts on the T cells at the G0 to G1 stage of the cell cycle, and it inhibits transcription process. All right, inhibits transcription process by inhibiting transcription process of all the cytokines. Here I've used the word lymphokine. Lymphokine is the word used for the cytokines produced by a lymphocyte. The T cell, activated T lymphocyte, that is especially Th cell, secretes large number of cytokines. They are called as lymphokines. And the synthesis of these cytokines is facilitated through the transcription of respective messenger RNAs. Majority of them are glycopeptides. They are undergoing post-translational modification after they are produced. They are peptides, but glycopeptides, and post-translational modification takes place to form glycopeptides. So it is observed that the activated Th cell against a particular antigen will be unable to secrete the respective cytokines. Just to recall back your memory, Th1 cells secrete IL-2, interferon gamma, and the TGF beta and TNF alpha. And the Th2 cells will secrete IL-4, IL-5, IL-6. And by inhibiting the secretion of these cytokines, remember, IL-2 is responsible for autocrine growth of the T cells. That is, it facilitates mitosis of the clonal expansion of activated T cells. So if IL-2 itself is being prevented from secretion or production by interfering at the transcription stage, that is G0, G1 stage, that T cell will not be able to further proliferate by the absence of IL-2. So inflammatory cytokines like interferon gamma as well as the TNF alpha will not be synthesized. Therefore, inflammation can be inhibited. And inflammation is another process that happens when the graft is done. It can be suppressed. Then IL-4, IL-5, IL-6 are very important cytokines which are responsible for B cell proliferation, B cell differentiation to form the antibody cells. If that process does not take place, T cell dependent B cell activation will not take place. And in the consequence, the antibody production also can be prevented. So this is how this wonder drug acts, by acting on the T cells at the stage of transcription of the cytokines. But it will not cause any other harm to other cells because it is specific only to the T cells. All right. Other cells which are dividing in the body, like your intestinal epithelium or other cells which are not concerned with the production of T cells or B cells in the bone marrow, they will be proliferating, those stem cells will be proliferating, and they will produce other immune cells that are responsible for protection. Therefore, it will not completely interfere with the other type of immune response except T cell immune response. And B cells that are dependent on T cells also will be suppressed indirectly. Therefore, it is not a highly toxic drug. Okay. See, it is also mentioned that it is not toxic to memory T cells which are already there in the body, and memory B cells which are already there in the body, and they are in the bone marrow especially, because which is a primary lymphoid organ. Memory cells are stored in the bone marrow, and it is not toxic to intestinal epithelium. Therefore, it is called as a wonder drug, except that in excess dose, it causes the kidney damage. It is nephrotoxic. Therefore, it has to be used in a very measured manner by the professional doctors, and it is not available across the table for without prescription, and it is given to the transplant patients as well as the patients suffering from autoimmune disorders, where it can prevent the T cells that are responsible for causing aggravated autoimmune disorder can be prevented from aggravation of the autoimmune disorder. And it is also given to the patients who suffer having different types of the T cell leukemias, and B cell leukemias. In T cell and B cell leukemias, the patients will have excess of immature T cells, excess of immature B cells. So B cell, they are also called as B cell lymphoma and T cell lymphoma. Leukemia is a generalized term, and T cell lymphoma is associated with the T cell proliferation, excess of T cells, immature T cells making their presence in the cancer patient who is suffering from T cell lymphoma or B cell lymphoma. It is used for treatment of those patients also, because it will prevent them from proliferation. Okay, because they are dependent on those cytokines. Then coming to the last example of the immunosuppressive drugs, that is corticosteroids. And these corticosteroids are anti-inflammatory agents used for various types of anti-inflammation, not only during the transplantation, they are also used in cancer patients to treat the cancer patients to prevent the inflammatory reaction, because cancer is also an inflamed area of the body which is being attacked by the immune cells, and we will come to that when we are going to talk about tumor immunology in this unit in the last part. So for the timing, you keep in mind the anti-inflammatory response is very important to control the flaring of the immune response and control the damage to the cells. Here, the tissue graft, which is going to be rejected and damaged, is because of the inflammatory response also, where TDTH as well as macrophage inflammatory response involving lytic enzymes, as well as ADCC response causing the damage to the cells, can be prevented from using corticosteroids. Because in the ADCC response, macrophages, eosinophils, neutrophils, and NK cells are involved. And those activated macrophages and eosinophils and neutrophils, if they are prevented from aggregation, and they aggregate because of the chemotaxis, and the chemotaxis is nothing but attraction. So the chemotactic process is going to be inhibited, means, we have come across neutrophil chemotactic factor, eosinophil chemotactic factor released by the mast cells, and corticosteroid is known to act on these chemotactic factors and inhibit their production. and inhibit their release. Because of inhibition in the release of these chemotactic factors, neutrophils and eosinophils will not be able to aggregate in the area where ADCC response has to be brought about. Same time, the monocytes which will get converted into macrophages and aggregate as macrophage aggregation factor, which is secreted by the T lymphocytes. That will also not, because the T lymphocytes will be inhibited from production of this chemotactic factor. So we have answered now the macrophage, neutrophil, eosinophil responsible for EDCC will be prevented from aggregation at the site of inflammation. Therefore, you can inhibit ADCC. Then comes the other mechanisms like the basophils and eosinophils, which are responsible for the release of certain cytokines, are also prevented from release of the cytokines. Okay, and the first cells to arrive at the inflammation are the neutrophils, which I have explained in the innate immune response. And how do they arrive there? They come at the site of the inflammation. They attach themselves to the blood vessel, and that attachment process I had explained that as margination, and they then squeeze out of the blood vessels, and the process I had explained that as extravasation or diapedesis. So the arrival of the neutrophils to the site of inflammation, then attachment to the blood vessels and extravasation, all that is prevented and inhibited by the corticosteroids. And one of the major cytokines that will cause the inflammation at the site also is the mast cells, by releasing the pharmacological mediators. And we have spoken about the primary and secondary mediators when we dealt with the hypersensitivity, type 1 hypersensitivity. And corticosteroids are responsible for prevention of release of pharmacological mediators. It will prevent granulation process by the mast cells. Thereby, release of pharmacological mediators is prevented. By preventing all these processes, one can control the inflammation to the great extent, to a large extent. It will also prevent activated macrophages from secreting IL-1, and the IL-1 is the warning cytokine for the TH cells to indicate that there is a foreign antigen. The macrophages that encounter a foreign antigen will secrete copious amount of IL-1 to warn the TH cells to get activated and come to the site where the antigen is encountered, to be presented with the antigen by the antigen presenting cells. That process will not happen. It will be prevented by, because IL-1 is going to be stopped from secretion. Similarly, secretion also will be stopped by the TH cells. If IL-2 secretion is not there by the TH cells cannot undergo autocrine activation or proliferation. Proliferation of TH cells will be also prevented. So now, if two important cells, that is macrophage and TH cells, responsible for the inflammatory reaction, if they are prevented by the prevention of cytokines, once again, half the battle is won. So, corticosteroids prevent inflammation by acting on the key inflammatory cells and suppress the inflammatory reaction. Therefore, cellular damage that is going to be caused by the inflammatory reaction can be prevented. But at the same time, please remember, it is not very safe. Just because it is an anti-inflammatory agent, if excess is administered out of enthusiasm, it will cause thymic atrophy. Thymic atrophy is nothing but ablation of the thymus, means loss of thymus. Once the thymic atrophy takes place, it is not possible to rejuvenate the thymus. It will die. The thymus will undergo degeneration. one need to take care not to administer excess of the corticosteroids. Second, it also triggers T cell apoptosis. Larger number of T cells undergo apoptosis because they are unable to divide. They are unable to get activated because IL-2 is not going to be secreted. And those cells which remain for a long time without being activated are sent for apoptosis or about to commit suicide. The T cell apoptosis takes place. Gross T cell apoptosis takes place. The another pseudo disease that is experienced by the people who are administered excess dose of corticosteroid is myasthenia gravis like syndrome. Myasthenia gravis occurs as an autoimmune disorder, but excess of steroid administered to a patient could result in a syndrome called as myasthenia gravis syndrome. But with withdrawal of the steroid, that syndrome will disappear. To give you an example, Amitabh Bachchan, when he had suffered from the injury during Coolie, when he was shooting for that, he was under excessive corticosteroid to prevent inflammation in his intestine. And finally, as he was recovering from the disease, as he recovered from the disease, the accident, he had suffered partially myasthenia gravis. And it was reported that he's having the problem of myasthenia gravis where he cannot close his eyelids. I told you that symptom of myasthenia gravis when a person willingly cannot close it. So that is what he had experienced. So, but on withdrawal, it comes back. See, so one need to be very careful. Once again, like cyclosporine, corticosteroids are also a good immunosuppressive drugs with less amount of side effects, provided you administer them in a measured quantity in the patient and can save the graft from the inflammatory damage. Okay, that is as far as the immunosuppression by the drugs is concerned. Now we'll lastly discuss about immunosuppression from monoclonal antibodies. There are now monoclonal antibody therapies available, which had discussed with you, and I told you that I will talk about this once again in transplantation. And remember, I had shown you this diagram when I had discussed autoimmune suppression by monoclonal antibodies. Okay, so there are monoclonal antibodies nowadays available which are directed against the IL-2 receptor. By blocking IL-2 receptor, one can prevent T cell activation. Similarly, there are monoclonal antibodies available to block CD4 receptor, and by blocking CD4 receptors, the signal 1 responsible for T cell activation can be blocked. Similarly, there are monoclonal antibodies that bind to the antigenic groove of the TCR, T cell receptor, antigenic groove of the TCR. And by binding to the antigenic groove of TCR, that TCR will be unable to receive the signal of the antigen that is presented by MHC, thereby preventing the T cell from getting activated to TCR. Then I'd also mentioned that TCR is always accompanied by a CD3 receptor. By blocking CD3 receptor, that CD3 receptor antibody is also, monoclonal antibody is also called as anti-TAC, anti-TAC, TAC, anti-TAC antibody, monoclonal antibody. By blocking CD3 receptor, one can block signal 1 that is going to be transmitted to the TH cells. So, by blocking T cell activation, half the battle can be won, which is already done through cyclosporine or through corticosteroids. If one can afford the monoclonal antibody therapy, one can block the T cells from getting activated. But once again, please remember that it is not possible to block only T cells that are going to be activated against the transplant. It is going to block all the T cells population that is produced in the body. So therefore, the reaction is going to be systemic. One will be deprived of the T cells during that process when the monoclonal antibody is in circulation. So the patient has to be protected against the intracellular pathogenic infections as well as the infections caused by the bacteria and viruses. And if it is not protected from those infections because of the deprivation of the T cells, the person may succumb to those infections. The other type of monoclonal antibodies I had explained, they can be directed against the antigen presenting cells. One of them is blocking the antigen groove of the MHC, class 2 MHC of the antigen groove of the antigen presenting cell can be blocked so that that antigen presenting cell will be unable to present the antigen to the TCR. That is one. Second, the antigen presenting cells produce B7 molecule, B7, and that interacts with the CD28, which is responsible for signal 2 for the activation of the T cells. So, by producing monoclonal antibodies and blocking B7 molecule, the signal 2 can be blocked because the monoclonal antibody bound B7 molecule will be unable to establish contact with the CD28. So when it is unable to establish contact with CD28, that TH cell will not be able to get activated because there is no signal 2 in the TH cell. In this TH cell, the CD3 receptor is also shown. That brownish receptor that is shown is the CD3 receptor which accompanies the TCR. The second possibility is you can have a monoclonal antibody against CD28. Instead of B7, CD28 also can be blocked so that it will be prevented from interacting with B7. Then we had come across two more additional molecules which are co-stimulatory. Those are CD40L and CD40R. CD40R is produced by the antigen presenting cell and CD40L is produced by the TH cell. And these two, CD40L interacts with CD40 by blocking any one of them using the monoclonal antibody, either CD40R monoclonal antibody against the antigen presenting cell or CD40L monoclonal antibody against the TH cell. One can block the activation of TH cell or the presentation of the antigen to the TH cells. These are the monoclonal antibodies which are expensive, available, can be used during transplantation to prevent graft rejection by blocking the main receptor like TCR or by blocking MHC receptor of the antigen presenting cell or by blocking co-stimulatory cells. So we will stop here today. Thank you very much.